Fertility Institute of Hawaii.
I'm John Frattarelli with the Fertility Institute of Hawaii. And we have a distinguished guest today, Dr. Greigh Hirata. I'll have him introduce himself now.
Hi, I'm Greigh Hirata. I'm a maternal fetal medicine geneticist at the Fetal Diagnostic Institute of the Pacific.
Thank you. So today we're just going to be having an open discussion about recurrent pregnancy loss. And if any of you guys are watching us, certainly you're welcome to post some questions for us to answer for you guys, or comments. We'll try to just kind of pay attention to the live feed here. Don't feel free to go ahead and interrupt us. So I think we can just kind of start out by talking about the definition of recurrent pregnancy loss. There have been a few different definitions and also, changes in terms of the definition of recurrent pregnancy loss. So, Dr. Hirata, what do you go with? What's your definition of recurrent pregnancy loss?
I use the 2 consecutive unexplained miscarriages definition. I think the data suggests that the likelihood of the 3rd miscarriage is as high as if you had 3 and having a 4th miscarriage. So I start the workup. I recommend the workup after 2 unexplained miscarriages.
Do you use 2 consecutive or 2 just in general?
I use 2 consecutive.
Yeah, I think we do the same thing as well. We oftentimes will have patients who may have scattered miscarriages throughout and have a couple of live births as well. Does that concern you at all? Let's say somebody's had 4 miscarriages, but they've had 2 live births kind of scattered in between. What would you do in that case?
Well, it would direct my recommendations a little bit, because if they've had normal children, then although not 100%, but familial translocations probably are less likely in those cases. So I'm not so worried about the genetics or the chromosomes as much. I mean, it's always nice to check anyway, but it's less likely. Yeah. So that would skew my recommendations for workup a little bit.
And I think it's important for the audience to know too that miscarriages are not uncommon. Somewhere between 15 and 25% of recognized pregnancies will miscarry, depending on the patient's age, and the amount of embryos that actually miscarry prior to clinically being recognized is much, much higher, because embryos end up being abnormal, or they just don't implant into the uterus for some reason. Mm-hmm. But having a clinically recognized pregnancy with miscarriage multiple times in a row is definitely concerning and deserves an evaluation. I guess that's what we can kind of talk about next, is some of the causes and evaluation that we would do.
Mm-hmm. It sort of depends on when you miscarry as well. I mean, if you miscarry very early, 8, 9, 10 weeks, sometimes without even an embryo, that has a slightly different etiology than if you miscarry recurrently at 12, 13, 14 weeks, which some people do. And I think the medical history makes a big difference too, because we know that there's medical illnesses that have recurrent pregnancy loss as part of their their presentation.
And are you more concerned with patients that if someone's having very early losses, 6 or 7 weeks, 8, versus someone who's having 13, 14, 15 week losses? Which one concerns you more?
Well, different reasons the different concerns for different reasons. And in the 8 to 12, 8 to 10 range, 7 to 10 range, I'm more concerned about chromosomes. And maybe, I'm not sure if you're a big fan of progesterone insufficiency, but I do believe that there's going to be some benefit to progesterone in those cases. In the 12, 13 week losses, that's classic for antiphospholipid antibody syndrome. They tend to lose late in the first trimester. And so I would probably pursue that a little bit closer, a little bit more vigilantly.
Yeah. And then I guess before we get into more specifics about some of the causes, and maybe we can talk about progesterone a little bit, that's always an interesting topic, but what do you think about biochemical pregnancies and those losses?
I was trained before biochemical pregnancies were even in existence. I think that's a little different. If you don't even have a stack, I mean, it's hard to say that's a recurrent pregnancy loss to me, but I suppose it is included in the whole definition. I suppose we have to treat those similarly, but like I said, the etiology is a little different for
Right.
as opposed to.
Yeah, less data. Definitely, there are some there's some suggestion that biochemical pregnancy is actually less associated with age compared to some of the first trimester losses. So there may even be less of a genetic component. It's so it's interesting and a little bit unclear, I think, whether it exactly goes into the definition of recurrent pregnancy loss or not. But usually, I don't know about you, but I sort of do this similar workup who've had a few biochemical pregnancies just to see if we can uncover anything there.
Well, yeah, and I think for us, for patients who are especially undergoing IVF, we have a limited number of embryos for those patients. So, if they're having biochemicals, we have to be a little bit more aggressive with looking at what the cause might be, as opposed to maybe someone who comes in who's had a couple of positive pregnancy tests at home and then it was negative when she went in. It might be a little bit different, but I can't start the evaluation on those patients just to do just to make sure that you don't miss anything. And I guess kind of just looking at some of the causes, just for the people who are listening, we've kind of talked about genetic causes, and we can talk about genetics a little bit more. There's obviously ages. As people get older, they're more likely to miscarry, and that's probably more of a chromosomal issue with the embryos as well. There can be uterine issues that we'll need to evaluate the uterus for. Antiphospholipid antibody syndrome, which Dr. Hirata mentioned, I think we should definitely discuss a little bit more. And then there's some questionable etiologies like infection, and definitely if somebody has a florid uterine infection, that definitely could be a problem. More commonly now, people are talking about more and more sperm, issues. Now that we're finding a little bit more out about sperm, but the cause of causing a recurrent miscarriage and that etiology being sperm, being the etiologies would be really rare and not high on the list. And then I think there's the lifestyle factors, which we never want to forget, right? So people who are smoking, drinking, a lot of caffeine, high BMIs, not taking care of themselves. I think that even though that's typically not going to cause recurrent miscarriages, it increases your risk for miscarrying every time you get pregnant. So you want to do everything possible to maximize your chances when you're trying to get pregnant.
I think you should also include medical illnesses, because although it's very rare, occult diabetes or thyroid disease, although it's rare, it's easily treatable. So that's why I work them up for diabetes and thyroid disease, because at least I know I can treat them. But as a cause of recurrent miscarriages, actually, it's pretty low on the list.
Right. Yeah, and to that end, like hyperprolactin, so high levels of prolactin, it will increase your risk. So all those things kind of increase your risk. They may not necessarily cause recurrent pregnancy loss, but if you already had a miscarriage and now your pregnancy risk is higher, you want to do everything everything possible to make it as low, to mitigate that risk, right?
Right, reduce the risk. I end, by the way, John, I end with the issue about infection, because almost every single article you see on recurrent pregnancy loss will have infection as an etiology. And I tell them, there's no way I can test for it. I can't treat for it anyway, but just remember that infection is the leading cause, just so that we've covered everything that you might have read about. And then, patients are very, very intelligent and very savvy. They go look on the internet, they look at all the lists. So I try to be as complete as possible. But yeah, infection is a big one. I can't figure out how to treat it anyway. I just have to mention.
Yeah, no, I think that's a big one for us too, because the testing for chronic endometritis is typically utilizing an endometrial biopsy and looking for signs of inflammation. It's not really even signs of infection, and then it's questionable. I think it can be pathology dependent. Sometimes in some areas you have a lot of chronic inflammation, and other in Hawaii, for example, we don't get a lot of reads that read chronic inflammation when we send out those those tests. So oftentimes we'll kind of treat them empirically, with doxycycline prior to an IVF cycle. I mean, in natural pregnancy, right, you don't exactly know when the patient's going to get pregnant. How are you going to treat it? You can't just put them on doxy all the time until they conceive. But when we're going to be doing, a embryo transfer, we actually can try and treat some inflammation. And so we'll use often doxycycline and a probiotic actually to try to.
You wouldn't for the entire pregnancy, though. You just
we just treat them once for presumed. I mean, if they have recurrent pregnancy loss, and we're not really seeing another clear etiology, we'll treat them prior to an embryo transfer with a longer course of doxycycline. Yeah.
I guess, for when we evaluate recurrent pregnancy loss, we may have a different statistic of probably about half of the patients we find a cause, and the other half we're not really sure what it is. And then we we go down another algorithm after that, and infection is one of them. Yeah, there was a study out of Stanford a few years ago where looking at the endometrium and doing PCR-based testing, where they did find that over half of the patients had evidence of chronic endometritis, and so for that reason we just give patients 2 weeks of doxy for that, and trying to find something that might be of benefit. You mentioned progesterone. As an option as well, and obviously there have been studies looking at that, and meta-analyses have shown that it's not effective. But then there's also studies that show that there's one study that shows that if you've had 3 miscarriages in a row, that it is effective. So it's harmless.
It's a benign medication. So right. I say,
right.
It may not work or may work, but if it does work, it's not much risk to you, it's just inconvenient. Right. I know that ureaplasma and mycoplasma are proposed organisms that can lead to chronic endometritis, and in my reading, the intracellular organisms like that you can't eradicate, and it's actually very difficult to culture. So what the PCR based test looked for, those two types of
Go back and look and see. I'll have to go back and look and see what they were specifically targeting.
Yeah, and I know you can't eradicate it anyway, so you could probably suppress it maybe for the time of implantation. That'll help, but you can't really get rid of that.
Yeah, and we're kind of working on doing everything we can to kind of suppress any kind of inflammation specifically for implantation time. But yeah, I'm not sure. I mean, I don't think the data for using antibiotics are very robust, honestly. So it's hard. But yeah, I mean, in terms of progesterone, that's the other tough thing about diagnosis, because it's become very clear that there's really no way to diagnose luteal phase insufficiency. That's not really. We used to think that endometrial biopsy would be able to diagnose that, and it became clear that we couldn't do that either. So that's another thing that we sort of treat prophylactically and say, well, sort of just in case this is the issue. I mean, with IVF, of course, we're treating with progesterone anyway, but for our recurrent pregnancy loss patients, we're achieving pregnancy naturally or through the use of IUI. Then we'll treat with some type of progesterone.
Yeah. So it sounds like we do recommend the same thing. You guys treat, and I give the recommendations for those things. And then I always like to underscore the fact that even though prenatal vitamins or some sort of vitamin supplement doesn't necessarily ensure that you'll have a successful pregnancy, it'll increase the risk of having a good pregnancy. So you have less likely having problems with birth defects related to folate deficiency or something like that. So I tell all my pre-conceptual patients you should be on some sort of multivite, and I think the minimum is 400 micrograms or 0.4 milligrams of folic acid. But it's clear that vitamins do decrease your risk for heart defects, spina bifida. So it's something that everybody should take.
Is there any? One of the questions I do get from my patients is, how long do I need to be on the prenatal vitamins prior to trying to get pregnant? I don't know the answer to that.
Well, I think folic acid is actually so water soluble that the levels fluctuate relatively quickly. So I think a month would be fine. Even a few weeks would be fine before. You probably have high enough levels of serum folate at that point.
Right.
I don't know what the right answer is. As soon as you find you're pregnant, you better be on. It better be before. Actually, it does so much more in terms of health benefits, and it's interesting. The statistics on who takes vitamins is pretty much inversely proportional to your age. So the older you get, the more likely you are to take it. The younger people don't take it at all. So,
well, I mean, having been a person who was pregnant and had to take prenatal vitamins, it's pretty awful. And had to work really hard to take them. I do make the recommendation, especially in the first trimester, patients to try things like gummy vitamins, which don't contain a lot of iron. I think or any iron really. I think it's the iron, and you probably don't need that much iron in the first trimester. Correct me if I'm wrong, but especially if you're not anemic with that initial CBC. And I think just for the patients who are watching, the gummy vitamins typically are much better tolerated, or vitamins without that additional iron.
It doesn't have to be a prenatal vitamin either. Any multivitamin.
Yes, anything that is acid or just folic acid actually alone is totally
I did know not to take too many fat soluble vitamins for sure. Vitamin A in large quantities can cause birth defects, and possibly vitamin E, although the data is not quite clear on vitamin E. So anything that you take in a gel cap, I call them, try to stay into the recommended daily allowance and not try to go over. I think 10,000 international units for vitamin A would be the guidelines.
Yeah.
So no extra vitamin A or no extra vitamin E supplements.
Just take it one a day. Keep the doctor away.
Well, higher doses of vitamin E can sometimes be used during frozen embryo transfer cycles to try and improve lining. We really use that protocol, but I have seen that.
Right. But then we stop it at the time of transfer, so they're not getting.
Right, they're not getting
as
much
when they're pregnant. So obviously, reasons one of the etiologies is patients that may have a translocation, so they have a karyotypic abnormality. So we do karyotypes on the patients, and the male and female partner, and it's about 2 to 3% chance that either one of them would be positive. It's a total of 5% chance that the couple at some point would be positive, and so we send them then to you if they have this chromosomal abnormality. Typically, it's a Robertsonian translocation. What do you tell them at that point? What are your guidelines for them at that point?
Well, first of all, Robertsonian translocations you can pretty much work out. If it's a 21-21 translocation, then all the pregnancies are going to have Down syndrome. So that one is easy. But some of the other Robertsonian translocations have a 1 in 6. There's 6 different possibilities, obviously, from six different combinations. 4 of the 6 probably results, or 3 of the 6 probably results in a non-viable pregnancy to begin with. So monosomy of some sort, or trisomy that's never been seen in a live-born. But the trisomic ones that may result in Down syndrome or Edwards syndrome are the ones that are more problematic. And because of natural selection, even though empirically it may be 33%, in actuality, the likelihood of a fetus having trisomy or trisomic for chromosome number 21, for example, probably is in the order of 5 to 10, maybe 15%. But they would benefit from some sort of either a DNA-based serum-based screening, like non-invasive prenatal or non-invasive prenatal testing, or a more diagnostic test like a CVS or an amnio. But fortunately, we don't see those very often. I remember seeing them in fellowship because they presented with infertility, actually, and it was not the mom, it was the husband that had the Robertsonian translocation. I had oligospermia probably as well.
Yeah.
And then for the Robertsonian translocation. So let's just say a balanced translocation. It really is so variable. You cannot predict what's going to happen because you can be missing pieces that could be significant that may result in a miscarriage, or you could be missing pieces that are not significant enough to cause a miscarriage, but might later on have imbalance in the chromosomes of the fetus that might result in some sort of a neurocognitive developmental delay, but you can't really predict. Everyone has their own unique set of breakpoints. That's why.
And that's why we send them to you.
Yeah.
Yeah.
And of course, there's the option to do in vitro fertilization with pre-implantation genetic testing of the embryos to,
Right.
when we know there's an issue, then we can test the embryos ahead of time. It sounds simple, but it's quite a challenge because, if only 1 in 6, 1 in 8 of these embryos are expected to be sort of unaffected, I mean, it can be very, very challenging to get enough embryos from these patients. It really depends on the ovarian reserve of the partner. It can be really a challenge to get enough embryos to be able to find those, those balanced embryos. So I definitely urge patients who know that they are balanced translocation carriers to definitely seek help, right away to ensure that we get as many eggs as we can safely and be able to get them the best success rate possible.
And just on the side there too, I think when you look at the IVF and doing PGT, we actually see that we don't see a 1 in 6 because we're testing at the blastocyst stage. So they're probably losing a lot of the embryos that are abnormal before they get tested. So we actually usually will find a normal embryo or two that can be used. In my experience, usually a third to half of the embryos are actually probably usable or normal, at least for the translocation. And so, I think you're just losing a lot of those embryos that are just not viable, and they just stop growing at some point.
Yeah.
So here's a question, because I know it came up, I think, with one of your patients. You have known aneuploidy in the embryos, and you don't have any more embryos left. And we all know that the phenomenon of trisomic cell rescue. What do you tell them? Should they or should they not? I say, for sure, you got to get testing afterwards. But
yeah, I tell them you should see Dr. Hirata, and whatever Dr. Hirata says is what we'll do. Well, I mean, there are two different, because I think there's also mosaicism, right? So we are sending more and more patients with mosaic embryos. Just for the audience members, mosaicism is where we find some cells from the embryo which are normal and some which are not. There's kind of low-level mosaicism and higher-level mosaicism, where low level would be if most of the cells are normal. A higher level would be if there are fewer normal cells but still some present. And the question is, is that embryo going to be a normal embryo, or is it going to be a mosaic abnormal embryo and lead to either a miscarriage or a child with live born child with issues. And so I think that at this point we're much more comfortable with transferring the mosaic embryos. We've kind of gotten our comfort up a little bit. I mean, not just us, but just the community, the reproductive endocrinology community, now that we know more about it, and they're good, there are a lot of data about normal children being born from those embryos. But the sensitivity for genetic testing in terms of aneuploidy is pretty good. And so, I mean, I will usually not recommend transferring an embryo that has a known aneuploidy unless that's not mosaic, unless the patient very strongly, I guess, desires it. Then I'll send them to talk to you about it. I don't know what your thoughts are, John. Or
I think for me, if it's the last embryo, it's the only embryo they have. And it's an embryo that's not going to end in a live birth, right? So it's trisomy 8 or something like that, or monosomy 5. Something we know that something that's not out there. Then I let them know, yeah, certainly we can do this transfer. There's a very small chance that maybe this was just an abnormality within the placenta, and the fetus can be fine. But if not, it's not going to end in a live birth. You might have an early miscarriage. And so certainly we could try that. But I would also, have them always talk to somebody like yourself first before doing anything like that.
Well, this is an issue that is intriguing because there are, as you know, chromosomes that have imprinting issues, 7, 14, 8, I think, too. And you would think that if there's a risk of uniparental disomy where you have an imprinted gene or imprinted chromosome, you try to shy away from those because although we can do invasive testing and try to determine if the two chromosomes are from the same parent, it is another layer that you have to add on to the whole counseling issue. But I know, we all know there's cases, and I had a very interesting case once about 4 years ago, identical twins. One baby had trisomy 18, the other baby was perfectly normal. So you know that mosaicism and differential or preferential normal cell line viability doesn't exist. And so it's hard to tell patients, there's no hope. There's always a possibility.
Yeah, and what I tell people, I mean, probably only about 50% of our patients are doing genetic testing anyway. So we're transferring these abnormal embryos all the time. And I tell people that although most embryos are abnormal, I mean, most kids are normal, and that's because of the fact that the majority of these embryos which are abnormal just won't implant, or they'll result in an early miscarriage. But the majority of the time, if I put in an abnormal embryo and I didn't know it, most of the time it just won't implant. It's nice to have that information ahead of time. I think again, it gives the patients a lot of closure and understanding when they have those results and understand, okay, all my embryos are abnormal and I'm going to move on to do another cycle versus proceeding with transfer after transfer, or perhaps having early losses and things like that. But I think we should also, because antiphospholipid syndrome is a big one. I definitely want to make sure we get that in, because that's something that we test for quite a bit, and it's something that we treat quite a bit. And so I just want to hear
something that we see differently than you, right? Because we see the early pregnancy losses, you see the later pregnancy losses, and the severe preeclampsia. That then potentially would lead to evaluation of patients.
Right. So maybe you can just take us through the definition and when you test for that.
Well, there's clinical and there's biochemical definitions that you have to surpass. The clinical one would be 2 or more unexplained consecutive miscarriages, or some sort of a medical condition, like unexplained blood clots. Some people include adverse or prior pregnancy as adverse outcomes, like severe early onset preeclampsia. And then the biochemical part would be significant antiphospholipid antibodies or anti-lupus anticoagulant, and it should be repeated 12 weeks. So that's the part that's oftentimes it's not done. They don't repeat it after 12 weeks. They just label a patient. And the antibodies do wax and wane. They go up sometimes, they go down sometimes. But it does make a difference for the way we treat them, because if we treat them with a combination of aspirin and anticoagulation, that's a long time to be on an anticoagulant. You have to worry about blood clotting and bleeding and reactions to the anticoagulant. Fortunately, they allow us to use low molecular weight heparin, but in the past, we'd have to use heparin, and it'd get these huge bruises in their stomach. It was really a lot of treatment. I have no problem putting anyone in aspirin. I think
it must be like such a pet peeve of yours when you see us put these patients on Lovenox.
I'm not quite sure what to do. And then there's after delivery implications. Because someone who really has APAS are going to be at risk for blood clots postpartum as well. So you need to treat those patients for 6 or 8 weeks with anticoagulation. And it's hard to, if you pull the trigger, it takes a lot. Because I know that it's a commitment on their part to take a lot of anticoagulants. And then there's a differing, even amongst maternal fetal medicine people, how much how much Lovenox to give them. You give them a low prophylaxis or a high prophylaxis, or some people even go therapeutic. And you can almost write whatever protocol you want, because there's someone always who has a protocol that matches what you're going to give. So you kind of have to if you give a low amount of Lovenox, 40 milligrams a day, for example, that's not as bad. I think that's probably less likely for you to run into trouble with. But if you're going to give them full anticoagulation, which is 1 milligram per kilo PID, that's a lot of Lovenox.
Yes, I mean, for us, obviously, when somebody meets the criteria for antiphospholipid syndrome, then they get treated with Lovenox and aspirin. But what ends up happening, okay, is that we have patients who they come to us. They've done IVF, I don't know how many times. They've had how many transfers. They've had 4 miscarriages, and the only thing that's positive is a couple of some low positive antibodies. And so I think we look at that and look at the clinical picture and what these patients have undergone, and we will typically treat them. And so I think that they don't really meet the criteria based on the low positive intermediate category antibodies. But I think we're kind of stuck in a situation where treating them with prophylactic Lovenox is probably the best thing that we can do. And I think, as you mentioned, treating with prophylactic Lovenox and low-dose aspirin is probably not too harmful, in particular in the first trimester.
And a lot of this, not just that we're treating them, that there's actually meta-analysis out there that's looked at trials for patients who've had recurrent implantation failure, recurrent miscarriages without any etiology, and treating them with Lovenox does significantly improve their outcome with the next treatment. So
that's actually regardless of the labs. That's just treating for kind of more unexplained implantation failure or recurrent loss without lab work at all.
Or do you continue for the rest of the pregnancy? What about after
12 weeks?
To 12 weeks, and then you stop.
Right. Yeah. That's what the other studies have shown, is it's up to 12 weeks, and then you stop it. I think that with recurrent pregnancy loss with antiphospholipid antibody syndrome, that 12 weeks is really hard. It's a hard sell for patients. They've been having miscarriages now, or infertility, either one. They've had treatments. This has lasted for so long, and now we say, okay, we think we have something. Let's wait 3 months and test it again. They're not very happy. So so obviously having them go see you during that time potentially. I typically will try to test them again around that 6 to 8 week mark, because if it's negative, then okay, they don't have the diagnosis. If it's still positive, then I talk to them about maybe trying to wait another month and getting to that 12 week mark to get a test, unless for some reason they just can't do it. I don't know. Does that sound like a reasonable plan?
I think that's reasonable, as long as they're not labeled as APAS. I mean, because sometimes they come with that label, and it triggers a whole cascade of interventions that may not be necessary. But it makes sense. You're going to treat them with some low molecular weight heparin just to get them pregnant and implant. You're treating them for their infertility, not necessarily for APAS. And the question is, do they continue that? Because you want to now make sure that they don't get a blood clot and the baby continues to grow.
Yeah, we would just need to make sure when we pass those patients off to the OBGYN that we always kind of tell them what the plan is. We tell them when we're stopping progesterone and baby aspirin if we have on baby aspirin, and Lovenox if we have on Lovenox, and then we leave it up to the OBGYN if they want to continue on for another reason, and they want to continue the baby aspirin or something else for some other reason.
Yeah, that makes a lot of sense.
What about? I guess just very, very shortly. What are your thoughts about some of the things that are out there in the literature that have been out there forever that really haunt us? the other, the inherited thrombophilias and the alloimmune factors that people, kind of, come in.
I laugh because,
stuff. They have their information.
Ooh, and I have to ask about MTHFR after. Okay.
I have to laugh because, maybe 15 years ago it was all the rage, recurrent pregnancy loss from, I think the relative risk was 2.2, something like that, for factor V Leiden mutations. And then it kind of went away. So I don't typically treat unless there's a significant family history, or maybe if there's more than one type of thrombophilia present, because they're so common. And factor V Leiden and the prothrombin mutation occur between 2 and 3, some say up to 5% of Caucasians. You could have both of them, and I think they're additive because they affect the blood clotting system differently. Or if someone has a really strong family history where they say their mom or their father or a sibling had a blood clot unexplained, I would treat them differently than someone who just has an asymptomatic factor V Leiden that was detected during a infertility workup. Like I said, I have no problem with aspirin, although aspirin is not a true anticoagulant. But I would shy against using Lovenox, and this is probably not your patient population because they're not necessarily infertile, but some patients come to me and say, I have the factor V Leiden, what should I do? I'm pregnant, I have never had problems with birth control pills, and I tend to not treat them. Now, postpartum is a different story because 50% will have blood clot. 50% of women that have blood clots in pregnancy have it 9 months leading up to delivery, and another 50% have it in the 6 to 8 weeks postpartum. So it seems like it's more prevalent in the after delivery, and that part you might want to consider anticoagulation for that 6 to 8 week period to get them through the hypercoagulability of in pregnancy.
Right.
That's how I approach it. Now, if they come because of recurrent pregnancy loss and that's the only thing you find, God, I'd have to scratch my head and think about that. I'm not quite sure.
Well, we're not, we're not doing that testing because, the literature has shown that that they don't have higher rates of miscarriage. Patients with miscarriage don't have higher rates of the inherited thrombophilias. So it doesn't really make sense to test the patients with recurrent pregnancy loss for these conditions when they don't have higher rates of it. There's not a strong association there. But we kind of oftentimes don't know what to do with them if they come to us with it. They sort of come to us with this testing and they've had miscarriages, and then it gets a little bit more dicey. I do want to bring up specifically the MTHFR mutations, and I think we have our REI data about this, and I want to hear what you think about that.
Well, MTHFR is also very common. And heterozygotes, which is one normal, one abnormal, typically don't have problems. But remember, it's not the gene itself, it's how they metabolize folic acid. And so if they're not exhibiting signs of hyperhomocystinemia, which is the end result of the mutation, then they should not be at risk for blood clots. So I just check a fasting homocysteine level. I tell them to take folic acid. And if the fasting homocysteine level is normal, I don't think they need much further. They need to take folic acid probably for the rest of their life, but that's about it.
Do you recommend testing for MTHFR mutations? How do you find these patients? Are you testing them under any symptoms? Are they coming?
Usually they come in because they've had a blood clot or they have a strong history of blood clot. So as part of the panel, I'm more worried about the common ones, the factor V Leiden, the prothrombin mutation. I get a fasting homocysteine level, MTHFR maybe. I might get a protein S and a protein C and an antithrombin 3. Those three are less common, but they're much more thrombogenic, especially the antithrombin 3. So they would compel me to treat them for sure.
Are you But you're not doing, just to be clear, you're not doing that testing with the recurrent pregnancy patients who have not had a blood clot. They just come in with recurrent pregnancy loss to you. You're not doing any of those tests for them.
No, those are patients that have had blood clots in the
No, you're not doing that stuff. Okay.
No.
And for, you said folic acid, is it, do they need extra folic acid, more than what's already in their vitamin, or what?
Well, if the fasting homocysteine level is normal with their vitamins, then they're probably adequately treated. Some people would put them on 1 milligram a day, which is prescription strength, I guess, is what one way to look at it. I wouldn't necessarily think they need 4 milligrams a day, which is what we use for patients that have had previous pregnancies with neural tube defects. But I would check their fasting homocysteine levels. And it's amazing how many people have normal fasting homocysteine levels, even the heterozygotes for sure, but I haven't seen that many homozygotes. It's not very common to see double mutation carrier, but those patients definitely need some folic acid.
Okay.
Perfect.
Is there anything else that you want to, just say to patients? I don't think, I'm not seeing any questions. I'm just seeing people telling us and you that they love you and us. So that's what I'm seeing on this. But yeah, is there anything else that you think our patients should know?
No, I think once again, vitamins, healthy lifestyle, things that you can control. Diabetes, absolutely. See us before you get pregnant so that we can get your sugars under control and improve your pregnancy outcome, for sure. Even though it's a very, very small percentage of patients.
Right.
Continue trying, because you never know how many patients we have between us that have kept on trying and eventually became successful.
And to end with that, I mean, the overwhelming majority of patients who've had 2 miscarriages and even 3 will go on to have live birth. So most patients will go on to have a live birth, kind of regardless, honestly.
Despite what we do with them.
Well, Greigh, Dr. Hirata, thank you for taking your time and joining us today. Thank you for your expertise, and thank you for taking care of our patients when we send them to you. We really appreciate all your guidance and your help.
Yes.
Thank you.
Thank you so much.
Okay, thank you.
Bye, guys.
Bye, everybody.